most of what I do is I grab data that's either the exact data or proxy data of studies that have been done, and I try to verify whether they were done correctly. And about 80% of the time, the answer is no. We need school choice for healthcare. After Corey DeAngelis signs that, after he watches Donald Trump sign the executive order, I think it's today actually where they're doing it. He needs to come to healthcare and be the healthcare voucher evangelist, because that's how we fix the system, and we'll be able to do more with less money.
Today to have with us Jacob James Rich. He decided to go with the triple name. I'm still sticking with two names, going traditional here. Total side note, I was looking for my birth certificate back. They actually had them back in the Paleozoic when I was born, but apparently they couldn't find mine. So I was thinking maybe I was Parthenogenesis or something like that. But it turns out there was a transcription error when I was born, so I had to go find under a different name. So I do exist, and Jacob James, you exist too, from what I can tell. Tell us in what vein do you exist right now? I've come across your reasonings at Reason, and maybe you can tell us the other reasons for your jobs and efforts right now.
Sure, yeah. So graduated from graduate school, Eastern Michigan, studying mathematics and economics back in 2017. Worked for Jeffrey Myron at the Cato Institute shortly after that. Worked at Cato for about a year. And then I got interested in opioid policy and other drug regulations. So I took a job at Reason as a drug policy analyst. And then I more and more got interested in just broad healthcare policy. And at that time, just coincidentally, COVID happened. And I looked at epidemiology. And in economics, a lot of the big things have been done because so many brilliant minds have looked at it. But I looked at what was being done in epidemiology and I thought, maybe I could do something here. There's a lot of low hanging fruit that still seems to be on the trees. And I've just been critiquing studies, critiquing methods. And that brought me to beginning my PhD in 2021 at the Case Western Reserve University School of Medicine. So studying epidemiology and biostatistics there. I worked at the Cleveland Clinic as a researcher for about 2 years. Worked in the lab. The legal department might have specifics on what my relationship with them was. I'm not exactly sure what that is, and they they've kept that reasonably vague, probably on purpose. But I was with them for a little bit, published a lot of research with them, and now I'm just trying to get into candidacy, finish up the dissertation, and then probably go back to Washington.
Well, there's a lot there.
Yeah.
It sounds, I grew up in a tiny apartment in New York City. We were kind of money strapped because they decided to send us to private school. So we had a tiny little 1-bedroom apartment for 5 of us. So I shared a room. Yeah, well, it was tight, but we were 3 boys growing up, so it didn't really matter that much. But we shared a bunk bed, and I spent the rest of my life, I guess, debunking. So this is I said it was set up for a bad pun, but it sounds like you are a little bit in the debunking camp. Am I right or wrong about that?
Yeah, I kind of call myself a replicator. Most of what I do is I grab data that's either the exact data or proxy data of studies that have been done, and I try to verify whether they were done correctly. And about 80% of the time, the answer is no.
So could you just tell me what's the little hook you have there? What's the kind of device the thermometer you are using?
Thermometer? Like, how do I evaluate whether
what's the metric by which you are evaluating whether these studies were done correctly?
Well, I've probably fully replicated about 7 to 10 studies. And if their results are magnitudes or even directionally different from what I come up with, then I say they don't replicate.
So fair enough. So you're actually redoing the experiments? I mean,
yes, I'm completely redoing the study from top to bottom. Yeah.
Wow. So that's intense. I mean, since they always seem to be getting $1 million grants, and they're doing them under $1 million grants, and I'm just assuming that you're not getting $1 million grants. I might be wrong.
Oh,
How do you?
you don't think Reason pays me $5 million a year
Yeah,
to
I
do
assume they just give you
replications?
a. I assume they have a like all you can smoke marijuana budget,
Yes, it does
um,
come with many benefits. Yes.
or maybe all you can vape or something. I don't know idea. All you can gummy. That's just a joke because my libertarian friends that seems to be the first, second, third, fourth, and fifth thing they mostly care about. Was legalizing marijuana, but now that seems to have happened.
Mhm.
But no, so maybe Reason doesn't give you millions of dollars. But so how can you replicate the kind of experiments, or just are you looking at the base data? What do you do?
Yeah, so the analyses I'm looking at, they oftentimes do get very expensive grants to fund them. And they'll have about 5 to 10 authors. And it's very interesting to me because the data they're using aren't data that they produced. When it comes to research, usually producing data is the expensive part. So maybe you have to pay staff to call people and do surveys. Maybe you have to contract with a hospital and get nurses to write down specific measurements that aren't typical. Like collecting data can be very expensive, but the research I look at, the data already exists. They're all publicly available, government provided data. And it really just takes one person with basic statistics training, probably
Right.
takes them about a month to do any sort of these analyses if they don't have like a recipe to do it already. So the fact that they already listed out their methods does make it a little bit quicker for me. But a lot of these methods are just very traditional. And if I was given the opportunity to answer a question, I probably would have reflexively used these methods anyways. So it is pretty interesting how disproportionate the resources are to conduct these projects relative to the amount of work that they actually take. Sometimes it takes millions of dollars to fund them, and they could probably be done with about $10,000 to $20,000 of resources
Yeah.
instead.
Well, yeah, I think government and some government ancillary functions don't really work that efficiently unless if you want to consider, leaving kickbacks and, skimming and all that kind of aside. Like I probably could have built as much train as California did for their high speed with, about
Well, I
35.
did because they're at zero, right?
I
Like,
know. So yeah, so it's one of those numerator denominator things. Um, yeah, so I could probably be infinitely and equally as good as they are. So you've expounded and written on some provocative topics. One that's kind of near and dear to my heart, if I had one, would be the opioid crisis, and it obviously wouldn't be near to my heart to have one, but some ways of addressing it and thinking about it. And uh, you were speaking about it on the liberal podcast. What do they call it again?
Project Liberal.
Project Liberal video slash podcast. You were talking about kind of legalizing heroin, and what are the other ways of addressing the opioid epidemic. I'll tell you my. Should I tell you my bias first or after?
Oh, go ahead.
Well, so I've
We
written.
might agree a little bit to your surprise.
Fair enough. My only complaint, whatever stipulation, is that you might have a little recency bias. Being, the old fossil I am here, I don't quite. I might have recency bias, but my recency goes back further. So I've written for brownstone.org, and I kind of posit. I posit that the opioid epidemic is really a creature and a child of medicalizing narcotic usage. We didn't medicalize cocaine usage. We don't have much change in that. We didn't medicalize alcohol. When I say medicalize, in the 60s, Vincent Dole and his wife Neislander, I think, at Rockefeller University, came up with the idea of replenishing a narcotic user's stock, dose, and they came up with the idea of methadone maintenance, and that kind of took hold in through the 70s and whatnot. And it basically they were dealing with kind of a weird experiment because New York City was fairly unique, maybe LA, a couple other places having anybody doing heroin. It was pretty much a non-entity throughout the United States through the kind of classic era of Prohibition from the 20s up until the 60s. So there was really no heroin usage going on in the U.S. extant. When I say zero, probably about less than 1% of what we have, in the 70s and 80s. And once they came up with that concept, they basically kind of changed the heroin. They didn't change the amount of heroin users proportionally, but they actually managed to what's kind of invert that. So the entire country was using at the same rate that the worst place in the U.S. was at that time. And so we basically grew and kept addicted a baseline residual buffer of users to narcotics, and that flourished a market secondarily. So I don't mean to throw something at you. I don't know if you're familiar with that or not, but a lot of the things that we want to do afterwards, a little bit like the little old lady who swallowed the fly. She swallowed the frog to eat the fly, swallowed the cat to eat the frog, swallowed the dog to eat the cat. So when we wind up coming up with other answers to deal with the opioid crisis, we're kind of forgetting what the fly was. Maybe we can extract that. So there's not a question there, but I mean, you could comment on kind of the maintenance aspect of narcotic usage, whether that is something sustainable or should be.
Yeah, so maintenance and medical treatment of opioids is very hard to navigate because the abundance of academic literature would suggest that it is the gold standard. Buprenorphine and methadone are the gold standard to keep people alive who are addicted to opioids. But as I just told you, like most academic research is kind of garbage. So I don't even know where to start to think about this. So I think about this in terms of incentives and whether corporations might have incentives to keep you hooked on something that they are profiting from. So if a substance could like if there was a pill that cured cancer, um, places that maybe cancer is a bad example because people do get over cancer. So I have to think of something that's a little bit more chronic. But like insulin for diabetes versus like a pill to fix diabetes, right? Um, it, you could definitely see companies that have long-term treatments to fix something trying to sabotage any sort of effort that would actually be successful in the short run. And it is a fact that the longer that you are addicted, the more that the buprenorphine and the methadone companies make on you. So I do think that there has to be some sort of way for people to access opioids safely if they happen to have an addiction so that they don't turn to the black market. I also
Right,
see
yeah. So
insidious. Well, go ahead. Yeah,
yeah, I'm interrupting you. I apologize.
you're fine.
Um, so we just don't happen to do that. Tiger Woods had a sex addiction. We didn't, give him interim. Women sent his way. People have gambling
But
addictions.
did Tiger go completely? Did he go completely monk, or did he just like temper it with like a long term
Who knows?
girlfriend of some
Who
sort?
knows? I'm using that really as kind of a.
Well, the examples are important, right? When we're
Yeah,
trying
well,
to
that was
get
that one
along.
was that one's somewhat for comic relief. So I
Sure.
apologize
Go
for
ahead.
that. The other one I would say is alcohol.
Hmm.
Alcohol has a far more dangerous medically more dangerous detox than narcotic usage. So
For
people
sure,
have
yeah.
delirium tremens, and they have a distinct chance of dropping dead if they were to go cold turkey. So that's something you have to handle much more gingerly. But we do that routinely. We put people in alcohol detox. We give them a little Valium or benzodiazepines. We kind of taper them off. We get them through that acute period, and then we recommend they go to AA and they have sobriety. Okay, we don't give them the hair of the dog. And if somebody has a cocaine or methamphetamine addiction, we taper them and so forth. They have the benzodiazepine addiction. We taper them. We send them on their way. Pretty much every drug, we say, oh, that's, I mean, you know, I'm going to stipulate these are all issues, and they can be traumatic issues and they can be very severe. Alcoholism, has far more kind of physical decay attended to it than narcotic usage
For
does.
sure,
Whatever.
yes.
So if you were going to, whatever, and again, it's much more dangerous to stop it. So if you wanted to do maintenance on one or another, you'd probably say alcohol because that's a much more dangerous detox. Narcotic detox is no fun. It's like being sick with the flu, say, for a week or 2 weeks, depends on who you are. But people who go to prison, I think nowadays they're doing a lot of narcotic replacement in prison. But historically, you go to prison and it's miserable. Prison miserable anyway, from what I hear. I haven't been there. But it's worse because but uniformly, I did narcotic detox with using Suboxone. I tapered to sobriety over a 4-month period for about a decade for my patients, and I saw a couple thousand people go through my office in that duration to start and finish and so forth. Not everybody did finish. I had about like 35% success rate, which I think is
Pretty
probably,
good.
yeah, it's actually pretty good because I was
That's pretty
personal
good.
about it. And I saw them all and I talked with them. And, a little bit of talking to me, people just, want to change their life or whatever. I'm trying to make a bad joke there. But anyway, um, but what they told me was the ones who had been in prison was that actually was some of the best times of their life. They were forced to maintain sobriety, as it were, and they were working out. They physically stronger. They gained weight. They gained health, and so forth. And a lot of times they maintained it, not maintained it with drugs, but maintained that sobriety for a given length of time. Obviously, if they were seeing me, they didn't fully forever. So people have, lapses and they have relapses and so forth. But the concept of kind of putting somebody on the hair of the dog in the alcohol term to put them back on the drug that in which they have an issue, I think is I personally think it helps the prescribers, the methadone clinics, the Suboxone clinics. It may kind of help the patient in the acute sense that he doesn't have to detox, but I don't really think it helps. It helps his soul. I don't think it helps moving away. And this concept of kind of diseasifying the underlying issue that you have this problem. And again, Vincent Dole and the originators of methadone theory, they called it a metabolic problem akin to diabetes. So they use this diabetes example. This is littered in the kind of liturgy of narcotic usage where it's like diabetes, but it's not like diabetes because, if you are a type 1 diabetic, you get rid of your needles and so forth, you'll die. And if you're a type 1, narcotic injector, you'll have a tough 2 weeks and then you're better, stronger than ever. So I don't buy that concept. I think it's traumatic to be on narcotics and traumatic to get off them to an extent, but that's by virtue of how we grow. Again, it's no really different from the alcoholic for whom we have the expectation of sobriety. But I think the base difference is, because I think you understand the economic aspect, is that nobody's prescribing alcohol. We have bartenders and we have liquor stores. We call them package stores, but there's no business model in medicine to replace alcohol.
Well, there is medication assisted treatment for alcohol use disorder, and various people who are on the pharma camp would probably say that the drugs for alcohol use disorder probably mess with the brain or stimuli the brain similar to alcohol in the same way that the opioids for medication assisted therapy would stimulate the brain. Now, I don't necessarily agree with that. That's just um, what the pharma explanation would be. And I was listening to you speak just there, and I realized that I think I slightly misspoke when we began, so I'm going to correct that. And I also realized this is going to be a fun conversation because I think we're going to have an opportunity to talk about some controversial things I think about. So, yes, I have multiple friends who have suffered from addiction, and the only way that they have gotten over their addiction is through abstinence. Typically, it's alcohol, but it's not just alcohol. But basically, most of them went to AA. They realized they had a problem, admitted there's a higher power. I'm not sure how much of the 12 steps necessarily needs to be done. It seems like it works for a lot of people, so I'm not against the 12 step at all. But end of the day, they just understand that they don't have control over the substance and that they have to uh, basically abstain from it for as long as possible, if not for the rest of their lives. And people who are addicted to opioids and similar types of narcotics and drugs, that's probably their best approach. The best way to address an addiction is to get yourself to the point to where you can be without it. And however you get there, you're going to have to get there. You're going to have to be very strong to get there. And you really don't want any taste of it around you because that's just going to throw you into the cycle of hell that you were in previously. Now, I want to address a little bit of what I said. What makes medication assisted therapy useful in the current legal environment is the fact that heroin and other opioids for recreational use are illegal. So alcohol, you the best way to get over your alcohol addiction is to abstain from alcohol, right? But you live in an environment where alcohol is legal. unless you have some sort of court order, you are able to obtain alcohol and drink alcohol if you choose not to abstain. The best treatment path forward is abstinence, but you live in a legal environment where that might not be possible. And various people in opioids and opioid addiction are coerced to go through treatment and are coerced to stop using when they don't want to. So if you have someone who's coerced to stop using opioids, second best from just having a completely legal market for them to access them legally in exactly what they want. The second best situation is probably pharmaceutical access through treatment, but it's definitely not an ideal situation. And I think all of the issues you were pointing at are actually correct.
You were talking about uh, abstinence as being kind of the desired endpoint for alcoholics. Um, what are your thoughts about kind of generalizing that for narcotic usage, and or uh, what do you think are the kind of institutional impediments from that?
Well, as I just said in the last segment, abstinence is probably the goal and the best approach to getting over any sort of addiction, and just realizing that you're not a slave to anything, whether it's sex, drugs, alcohol, or even like riding motorcycles. All sorts of behaviors can have destructive elements to them, and some people struggle with that. And if they realize they have a problem, oftentimes the best approach is to just cut it out from your life. Like if your arm causes you to sin, cut it off. The institutional things, I don't know. There's money everywhere. The government incentivizes various types of treatment. There's been more and more money going towards addiction therapy, and I see it even uh, seeping into healthcare that isn't even addiction related. Like there's more and more prescribing of buprenorphine and methadone for pain, and then there's also regulations on various types of activities for using those types of drugs. So even if you have methadone prescribed for pain, the ATF, the Bureau of Alcohol, Tobacco, and Firearms, they make it very clear that if you take methadone, you're not allowed to own a gun. And there's a lot of rights that are actually suspended from you for taking buprenorphine or methadone. And I really doubt that they can actually decipher who's receiving it for what types of conditions and whatnot. So that's a very difficult question to answer because you just have money incentives everywhere, whether it's an addiction, prescribing, healthcare access, and then you see various types of institutions uh, basically emerging. Like basically, the government wanted to put more resources towards addiction treatment, and that's when buprenorphine really caught off or caught on around 2007, right? So
Mhm.
the government puts resources towards any sort of
Yeah,
treatment or resource, you'll see various institutions
yeah, that
emerging
which
that money.
incentivizes grows. No, I agree with you. I personally think they do a very, very bad job, federally and state level, in the health business. Um, I think it's fat-ish, not fat, um, but fad-ish with a D, a double D there. Um, and I think they pick and choose political things by which they decide what is healthy at any given moment.
Sure.
Um, I there's studies, they may be false studies. We'll have to have you go through them, that show that people live longer when they are married. And the joke aside, they just feel that way. But um, they live longer if they go to church. They live longer if they're part of a community service of one type or another. And maybe the latter one might get emphasized, but I don't think there's been like a food pyramid for getting married or having kids or being part of a church and so forth, which are kind of foundational. I mean, I don't think they magically do anything to improve your health, um, but I think being married. I've got my little mini handcuff here, and that keeps me from doing things that are like wild. I don't go out and road tripping. I probably I'm not going to put on one of those flying squirrel suits and jump off a cliff. A lot of things I just don't wind up doing. I was never much of a drinker, but it's all kind of tempered by the fact you have somebody else there. Having a dog probably makes, extends life because you have somebody for whom you have to care, etc. And so those things tend not to get emphasized. And at any given moment, it seems like the public health, will decide one thing or another. I mean, we've seen kind of very recently this kind of transgender stuff, and I believe some of the
Don't get me
studies
started on that.
say what.
So don't get me started on that one. That's
Well, please go ahead. I'm going to give you a nice runway, and I'll shut up.
oh, you're fine. Yeah, transgenderism has challenged my libertarianism. Oh, I don't even know how much I should say about this, but I do believe individuals and adults have the right to make their own decisions. But then various types of people probably aren't able to make their own decisions. I have a very good friend who I met in college, and he has special needs. And because of his specific situation, if he's going to open a bank account, his guardian has to be there. He's a little bit older than me, but he has cognitive issues. And he's one of the most wonderful people I've ever met. I almost feel like if you are born like that, you have a ticket straight to heaven because all he does is he just calls me. He just calls me to ask me if he can pray for me and ask what I actually need prayed for. And that's basically what he does. He just goes around being very nice to everyone, and he's awesome. But he can't make various decisions for himself because of his cognitive issues. And I'm not going to reflexively say that applies to anyone, or I mean everyone who wants a trans-related surgery or to attempt to do a sex change. But at the end of the day, these procedures are inherently harmful. They hurt you. They will reduce your life expectancy. They are serving absolutely no type of health function, and a matter of fact, they are actively making you less healthy. So the idea that a doctor could provide those services without reflexively violating their Hippocratic oath is absolutely absurd to me.
Yeah.
And we're going to be having more and more conversations about this as this issue goes forward, regardless of the political climate. But the popularization of these surgeries, regardless of whether you think they should be legal or not, is absolutely appalling. I know you mentioned a bunch of other stuff we should talk about too leading up to that, but I kind of forgot what you mentioned.
That's fine. That's fine. We can kind of hang out on this. I remember like 15 years ago, there was during the Bush George W. era, there was a kind of an uproar here about clitoridectomies being performed in Egypt, Sudan, and let's say Muslim countries here and there, and importing it to the United States. And you don't really see much about that because it was seen as kind of a heinous, brutal act to cut off sexual function of a woman, and the possibility of sexual pleasure. And so clitoridectomies are still done. That hasn't stopped. It's part of religious practice, and I've never been near one, nor have I knowingly seen a patient with one, etc. But that's kind of gone from the stage. You cannot, in a way, talk about clitoridectomies and eschew and abjure them and want them undone when you're doing that. It seems when you've kind of gotten into the sexual mutilation industry yourself to a certain extent here. There's I think it's I don't know all the mechanics that's going on with the quote unquote sex change, but they're doing things on probably a similar level. I'm not sure you can have orgasmic pleasure, after your parts have been kind of rearranged and whatnot. And I think there's kind of a weird, different kind of chattel slavery aspect to it. People see the clitoridectomy under Islam as a way of keeping the woman in her place, so she'll just be at home and produce children, and she's not going to be out and about pursuing sexual pleasure and so forth. It's kind of like a almost like a branding and an enslavement. But I'm not saying it's the same thing. It's not. And I'll probably get in trouble for saying this, but what's happening here is a different type. It's kind of an enslavement towards the medical process. We were talking a little bit about methadone, and that kind of brands you as having to go see a doctor for interminably, but let's say a decade, your life, whatever, you have a narcotic addiction, you need to keep seeing this doctor forever, get your kind of methadone communion. It's a little bit easier now. They changed the rule about a year ago, but historically you have to come in every day and get your dose and so forth. But this genital surgeries and this quote unquote gender affirmation, which I think is a denial, is pretty much keeping you in touch with your physician forever. It's a good business model for the doctors doing this. They have a customer forever. At least get hormones of one type or another and whatnot.
At
And
least the industry does.
say what?
I said at least the industry does, even if you change your doctor.
Right, fair enough. Well, ditto methadone. I mean, I could be a
Mm-hmm.
methadone user, and I go to Cleveland tomorrow, and I'm going to have to find a new one.
Mm-hmm.
Frankly, that brings up a second point, which is, different from the alcohol sobriety model. A lot of my narcotic addicts, they were coming to me for Suboxone, and some of them have kind of flaky, shady excuses for missing and whatnot. They have like 6 or 7 grandparents per person because one of them keeps always dying. My grandmother just died; I couldn't come in. It's kind of a medical joke, but the narcotic addicts would always say, "Oh, I couldn't come in because my grandmother." But if you actually tallied up how many grandmothers they had, it's like more than the few that were granted. Anyway, but if they wound up in a different town for something, they didn't have the Suboxone, but they had this innate addiction. They had to go feed something. Whereas the alcoholic might go to a funeral in Pennsylvania and not need the alcohol because he's already sober. So it's kind of a continuing narcotic burden, a physical need you have when you get off your maintenance for one reason or another, that you have to have something. You have to go back to that. You never kind of break away. And in the same way, the transgender stuff is like you're never going to be able to break away from your physician. That's an eternal aspect, it seems.
Yeah, I agree with everything you just said.
Oh my
Uh,
God!
I
So
don't
now
know how
we have to have an argument. Argue with me. Argue with me. Come on.
oh man, how do I argue with you? Um, I do know multiple people who have gone through the I want to say this in a polite way, but I also want to say it in an accurate way, the quote unquote sex change surgery. And they seem to be competent people who are capable of making their own decisions. I don't agree with what they did, but I do my best not to judge them. And I don't think I judge them. I think what they did is wrong, but I have plenty of friends who I think have done wrong things who I still love and cherish and consider very close to me. So I've, like I said, my libertarianism is challenged on it because I reflexively want to say that anyone who wants the surgery is not capable of making the decision that they should have the surgery based on the fact that they want the surgery, because why would you want to do that to yourself? Just as, if I go down to the hospital, if I go to the Cleveland Clinic right now and I say, I identify as a one-armed man, will you please chop off one of my arms? They won't do it.
No.
In fact, I might get I might be reported to
Yeah,
the
you go to the psych
authorities.
hospital. Right.
Yeah, no,
That's warranted
exactly.
on your. Yeah. And as a physician, if you were really intent and serious about that, you have the method and the means and the wherewithal to go do that, I would probably have to, section you. I would probably have to commit you to an involuntary psych unit for wanting to do irreparable harm to yourself, potentially up to the point of taking your own life.
Yes. So that's where my libertarianism is challenged because I feel like I could try to be extreme about it, but I'm not going to be extreme about it. It's probably a good thing that you're not allowed to do that to yourself. And then it's not much of a leap to say various people shouldn't be able to remove their genitals. Actually, I think removing your genitals is much more harmful than removing your arm. But then again, I again know competent people who have made that decision for themselves. And I also think, who am I to make that decision for them? But I don't know what percentage of the population of people who are going through, who are actually consciously making the decision to get those surgeries, they actually represent. And I'm very confident that a significant proportion of the people who go through those surgeries are regretting it and they're being actively harmed by the mind virus that's telling people that this is okay.
One of the things you have spoken about is nicotine, vaping, kind of the unequal panorama of quote unquote justice out there to help cigarettes disappear, people get healthy, all that kind of stuff. I'm going to give you a local example. I don't know if you've heard about this one. I live in a state of confusion, but also sometimes called Massachusetts. Actually, we're a Commonwealth of Confusion. Maybe a good alternate name. Commonwealth of Massachusetts. Newton is a leafy suburb due west of Boston, and in its wisdom came up with a law I've never seen applied anywhere else. I don't know if you know about this, but basically, if you are born after something like March 31st, 2004, here on in forever, you'll never be able to buy cigarettes. So what they're doing is they basically have like a moving train, a cohort of people who are going to be ushered out of life as they get older who can still buy cigarettes. So like the standard kind of cartoon or back in my days, a 12-year-old goes, taps somebody who's 20, go, can you get me a beer or something like that, or cigarettes, whatever, because there was an age limit. So that 16, 18, 17, whatever age limit is going to be for you forever. So when you're 50, you're going to have to go find a 52-year-old to buy you cigarettes because your age group, your cohort, 2004, born 2004, and in 2054, you're still going to be too young. You're going to be forbidden to buy cigarettes. So this is just kind of a mind-blowing one. I don't know if you've ever heard of that one.
Oh, I'm aware.
Are you? Okay, fair enough. So I don't know if you want to talk about that, what the legality is there, because I imagine over the time it's going to be booted out from the courts. But it's done in Brookline, which is another leafy suburb, lefty, leafy, liberal suburb of Boston. What's going on with nicotine, this kind of concept, so forth? And is this just kind of smarmy nannyism?
Yes, it is nannyism. What the motivation is, I'm not exactly certain because you have various organizations and public health institutions that legitimately have a motivation to reduce smoking and various harms that are caused by tobacco. And it seems like their approach is incredibly non nuanced, meaning that health isn't the major driver of the decisions and policies that they put forward. Because if you would ask these public health tobacco controllers whether they would ban all vaping right now, they would probably say yes. And then that would increase smoking, and then that'd be actually bad for health, right? So I'm not exactly sure where their motivation is. They're just prohibitionist. Just tobacco is the enemy. Anything that provides nicotine needs to be banned. And their approach is to choose the products that have the smallest constituencies, knock them off first, and then increasingly go after products with larger constituencies. So when the Tobacco Control Act of 2009 was passed, it reflexively banned flavored cigarettes. And the argument was that, well, flavored cigarettes are for children, and these are disproportionately bad compared to regular cigarettes because they're flavored. But if you ever looked at the data on who used flavored cigarettes, it was basically no one. It was like less than 1% of all cigarettes being sold. And children who were using cigarettes were disproportionately using non-flavored cigarettes. So there's not an actual motivation for
No.
this. It's just they see that no one's going to defend them, like, oh, we can ban it, and then they go and ban it. And yeah, you don't have a lot of voting constituents voting to protect tobacco use among a population that's not even old enough to vote yet, right? So that's basically what they're doing. They're just identifying the smallest constituencies and trying to prohibit the product for them, and any unintended consequences that follow. I guess they'll deal with those later, but they will be caused, as Massachusetts itself has actually seen through its menthol cigarette ban.
Yeah, I remember you spoke on that podcast, and it had some kind of secondary aspects they didn't predict, but it was mostly because we charge so much for tax here that people kind of found a cheaper way to get it across the New Hampshire border.
Wasn't that interesting?
Yeah,
Yeah.
I mean, you kind of had me hooked there a little bit. No pun intended, because we're talking about addiction, but it is kind of a funny exigency because we are Taxachusetts, in two other random states that prohibition might very well work. It seems to me that a lot of taxation is just that. It's kind of more smarmy nannyism, and when will they stop it, or we're just going to get different ones? Like I voted for Donald Trump, and I'm very enthusiastic and pleased by what's been going on, cutting this and that and whatnot. Because I think most of the functions of the federal government, outside of perhaps applying justice, although our judges are kind of whatever, make you doubt that, and allowing interstate commerce and keeping these states, as it were, which were almost on the level of nations back when the term was created, United States of America, keeping them all at peace and protecting the outer border, blah, blah, blah. Okay, but a lot of this other stuff is just transfer based on theories. So people are getting grants for studying X, Y, and Z, and they can be very mundane things, and they can be silly. And sometimes they can be illuminating, but if they're that illuminating, they probably should be handled, through their own impetus, people really wanting something. But I think, if we were to go through, you've looked at a lot more studies than I have, can you tell us, like, I guess this is not really where I intended the question to go, but while we first in mind, what do you think is going to happen to, epidemiology or to medicine or to whatever when, some of the money gets diverted from a federal sense? But I guess the question I was kind of leading into was, I would like the federal government to get, HHS and whatnot, to kind of get out of the health business. Even if we were to replace the current foibles with, Robert F. Kennedy's ideas about food and whatnot. I mean, I think it's okay to have an open mind about these things, but I don't really want the government pushing one thing or the other.
Sure. That's going to depend on the courts, as you know. There's a lot of cuts that have been made to contracts that NIH has already promised. It's not clear whether those cuts can go forward. It's not clear if the courts say the cuts can't go forward, if the courts can do anything to enforce the executive to just do the cuts anyways, right? There's a lot of uncertainty, unitary executive theory, and all of it above. If the cuts do go forward, I think there is a very important place for epidemiology, but it's going to be completely dictated by how CMS under Dr. Oz is, just completely reconfigured. If Medicare and Medicaid can start turning itself into a voucher system instead of a provider system, I think you'll have much stronger incentives for good research to come from epidemiologists and pharmacologists and all sorts of healthcare researchers. We just don't have the right incentives in place at the moment. But if we got to a system where CMS was giving vouchers to various eligible types of people for where they could buy private insurance, then the insurance itself is actually going to motivate.
So this is like the school choice.
Exactly. We need school choice for healthcare. After Corey DeAngelis signs that, after he watches Donald Trump sign the executive order, I think it's today actually where they're doing it, he needs to come to healthcare and be the healthcare voucher evangelist, because that's how we fix the system. And we'll be able to do more with less money. That's exactly what happens.
For my taste, it would be to get rid of the middle person. I mean, public schools, I think, maybe had a place. I went literally to Horace Mann School in New York City, but that was a private school, ironically, named after the guy who invented public school, actually locally here, just right outside of Boston, 19th century Horace Mann. And his concept was that there was a huge immigrant influx and they needed some kind of common denominator so everyone would literally and figuratively speak the same language. They have some basis in facts to understand where they were. They weren't in Poland anymore. They weren't in Germany. They weren't hither and yon, and they were going to be American and Americanized. I think that the experiment, kind of like, I forget who did it, but if you put the word public or private in front of any noun, you'd rather do the private. Public swimming pool, private. Public housing, private housing. Public transport, private. You always want the private. And so I think public school, if the money never got into the city government in the first place, and most of it winds up going to this kind of huge kind of fluffy layer of administrators, so where they weren't providing the product. What you wind up is basically the metaphorical aspect of the one guy digging the hole and 13 guys, wearing the same, stuff, watching it. What we've gotten to is a lot of situations where throughout medicine probably as well, there's a lot of, ancillary stuff getting, surrounding the actual interaction, which is, say, doctor physician or doctor or patient, doctor patient or patient machine, and a lot of that stuff could be, I think, done better if it went to like a vending machine model, where you had the ability to go buy the thing you want. People, I don't think they would go frivolously and get an MRI, every 5 minutes. I mean, if you had the money to do that, maybe, but people go through a lot of grief, they have the back pain and they no, you're not getting the MRI yet. I listened to your conception of what our medical system is, not capitalist per se. There's this big social kind of layer to it, but on a different aspect, I actually call the model parental. Which I think is like, if you're a teenager, you're 14 or 15 and you want to go into town, you ask for the car. You can't have the car. You haven't done this yet. And even if you're 17, you don't get the car. 18, because your parents might say no. You go to the doctor, it's like, I would like you to test for uric acid. I think I have gout. No, I don't think that's what it is. We're not testing that. I want to get an MRI. My back's been killing me for 6 months. Not yet. A lot of it just seems to be this parental model where the doctor is the loco parentis, teaching you and treating you like a child. And I don't think we have that with some of our equally big purchases in life. You want to buy a house or not? You want to get married or not? I mean, those things can be consequential almost to the same extent as knowing whether you have gout or not.
No, they're more consequential.
Fair enough. And yet we don't have to go through that. If you have the means to buy, your whatever Maserati, God bless you, go buy it. I don't really have a say in it. I don't really care, what you do with it. You need some kind of insurance. So when you crash and you hit somebody, that's covered, whatever. But whether you have comprehensive for your Maserati, I don't really care. And so if we can kind of stay out of each other's way, I think this stuff works. So I kind of looking for an HHS that doesn't, because RFK likes this and that, I don't want to hear about that either. I'm not saying it's better or worse, but I just think it's like, he can do that. He can be a model physically for every 71-year-old who wants to, be buff. Well, go for it. But I just think that most of what kind of gets promulgated is like I said, fad-ish. I don't know how you feel about that.
Well, the first time I started thinking about healthcare policy, I was an undergraduate at Eastern Michigan, and my ear really hurt. And I suspected that it was an ear infection. And then I looked up what an ear infection feels like, and I'm like, this feels like an ear infection. But I couldn't just get ear infection drugs. I had to go to the doctor. So I went to the urgent care, and the doctor said, your ear hurts, but I think it's because you have allergies and your sinuses are clogged. And I said, that's interesting. Can you just give me the ear infection medicine? He's like, well, I want to give you a prescription for allergy medicine too. And I'm like, well, actually, at first he was only going to give me the prescription for allergy. And then I had to convince him to give me the prescription for both. I didn't fill the allergy medicine, just filled the ear infection medicine. And then voila, it was gone. And ever since then, I've been thinking a lot about the middleman aspect of various uncomplicated healthcare procedures and how easy it should be to access various types of healthcare without a doctor. But you have various lobbying mechanisms from the American Medical Association and other healthcare providers that purposefully put these regulations forward in order to enrich their constituents, their members. So you're up against that to fix the system.
I think it's going to be the Soviet model. No, not of healthcare, but of ending healthcare. That is, the Soviet was there. Herb Stein, who was Nixon's Council of Economic Advisors, he said that which can't continue doesn't. Brilliant, right? I don't know if you've heard that quote. He's Ben Stein's father. And so the Soviet, it was there. It was a big threat. And then one day it wasn't there anymore. It just basically, decentralized and fell apart. I think, a lot of the AI generated, knowledge we have, it's not AI, but it's knowledge. I mean, the internet, same thing, is kind of disintermediating and eventually, kind of taking away the doctorness of the doctors. And you pointed out that doctors themselves are not really doctors anymore, as much as kind of part of a
The
medical army.
flowchart followers, yes.
What did you call them?
I said they follow flowcharts.
Yeah, they're guidelines.
Mhm.
They're line guided, I guess.
Yes,
And so they're
they're,
not.
they're bowling with the bumpers up.
We actually did that not that long ago. It was the place had a lot of kids there, and it was nighttime, and we wanted it down, but like no, we just leave it up, and so we got these crazy scores from bad bowlers, and plus there's a little. I don't know if you've ever seen the ones we have in Massachusetts, the little candle, these handheld balls. I mean, they're both, but anyway, it's just weird stuff. Anyway, yeah, so there's a lot of stuff where things are this is kind of this extra layer applique. So we're kind of rounding out our hour here, and I frankly find you fascinating. I could have you on for 8 hours, but I'm not sure I can afford you. So give us
Well, I
kind
don't
of
have the PhD yet, so I'm cheap at the moment.
yeah, fair enough. Um, so the thing that really fascinated me was the number of studies that are factitious, say, or uh, false and whatnot. How much of it is intrinsic to the desire to get a specific result? I mean, is it always going in one direction? Is it kind of random? We're falling on this side or the other, or does it kind of fall in line with the expected thing, the thing that people want to hear?
No, it's definitely not random. If it was random, then the bias would be split 50-50. And what I always find is that the bias is always towards the ideological position of whoever's writing it.
Yeah, yeah. Well, fortunately, we're not biased.
I mean, we are, but whenever I put out a study, I try to publish my data, publish the code, and say, you guys can come after me. You know where I stand and you
Right.
know what my bias is,
Yeah,
but you have to confront that I'm putting forward a good study, it's replicable, and that it's very predictive and uses predictive theory. And that's what we need to push academia to start doing more, to be more transparent.
I appreciate that. And so, in our last minute, give us the Jacob James Rich 1 minute overview of COVID. What went right? What went wrong?
All right, yeah, 1 minute's totally enough.
2 minutes. I'll give
Um,
you. I'm generous. 2 minutes.
no, we can do it quickly. Uh, Long story short, we forgot that people react to incentives in a reasonably rational way. And through fear, we allowed very evil people to set the policies and enrich themselves. And lots of people died. And if the government would have never reacted to COVID, way fewer people would have died.
I don't think I could have done better. I've written on this topic quite a bit. Um, yeah, no, it's a
It,
mess.
it's really sad. Like I'm a huge fan of Milton Friedman, and before COVID, there's this famous Hoover segment when he's talking about which departments of the federal government need to be cut. And then the host, I forgot his name, he's really cool, but the host brought up, oh, CDC, we'll cut that. And then Milton's like, no, 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 no. There is a federal reason to have contagion control. And I always thought the field I was going into was like the weird libertarian counterpoint to various types of government that has to exist. And then after COVID, I'm not sure anymore. It's really sad. I wish we had a functioning CDC that kept us safer.
Yeah,
And I hope one can exist.
yeah, I agree with you there. So we're rounding out the hour. I just tell you and my listeners, I wrote a book called Overturning Zika, the Pandemic That Never Was. And that was a thing back then, about a decade ago. And we spend $1 billion, and it's like 1 billion people throughout the tropics are theoretically affected by the news, as it were, that this, you know, mosquito-borne virus can inalterably change a cherished life during pregnancy and give you, a sadly reduced child with microcephaly and cognitive issues and so forth. It never recurred anywhere, even in Northeast Brazil, and nobody's puzzled over it. Like literally, nobody's puzzled over it except for this guy. and that's not my field of expertise. I'm a primary care doctor, so I endeavored to write to about 889 um, email address authors on these various studies. Thousands of studies have been produced since then. There were like 0 studies of Zika before. Now there are thousands of studies. And my response was to, get people to look at my stuff, which is kind of a epidemiologic debunking. I guess I went back and looked at primary sources of how they came up with their stuff. And like nobody has an interest in this at all. Nobody will talk to me and so forth. And I haven't been able to lecture anywhere aside from the interwebs and whatnot. Anyway, so I think you're making some reasonable points out there. There's like kind of a way that people conceive of things, and if they're getting paid for that, it's going to be hard for them to decide anywhere else. Um, so thank you so much, and I appreciate you being on here. Will you ever come on my show again?
I'll be back, Randy, God willing.
All right. Well, thank you so much. That was Jacob James Rich, and that's all for today.